Hey guys, am I audible and visible? A very good evening. Can you see me, hear me? Hello. Okay. I hope I'm audible and visible, guys. Sorry to start late. So yesterday we had to stop and between. That's why we are going a little bit early today. We'll be starting from wherever we left yesterday in the intestine. We'll go with intestine. Good evening, Upshita. We'll go with liver. I want to just talk about one disease in liver and like Christian asked for a LFT, a brief review of liver function test. And then we'll go to female genital tract. Female genital tract and breast might not be that important, but breast cancer, there's a very high possibility that it can come in a long answer. So we'll be definitely discussing about that, right? So if you're ready for the game, let's start. So we do, I hope you do remember the template. For everything with respect to systemic pathology, apart from glomerulonephritis, we have a line or two about the disease, risk factor, etiopathogenesis. If it's a risk factor, we call it a risk factor. Etiology, we call it an etiology. And along with that, pathogenesis. Then you have clinical features, gross, microscopy, IHC if required if it's a carcinoma, and obviously the complication in the outcome of it, right? Okay, so let's start. So IBD, there is a very likely possibility it can come in a short note, be it an Crohn's disease as in a short note or an ulcerative colitis as in a short note. The etiology risk factors more or less the same, right? So if it's Crohn's disease, you can write Crohn's disease and immune-mediated chronic intestinal inflammation resulting from inappropriate mucosal immune activation. If it's ulcerative colitis, you can write the same for ulcerative colitis as well, right? That's a basic normal thing, right? So we do have risk factor, two thing risk factor because both of them are autoimmune disorder, autoimmune inflammatory disorders, right? So now everything is autoimmune inflammatory disorder. Like we read in the template in the 6th chapter of general pathology, we have a genetic risk factor, we have a problem in the immune tolerance, and also we have an environmental risk factor, right? So we have sporadic, called as an hygiene hypothesis. If you want to elaborate it, if it's a long answer, you can write that more hygienic you are, there is less training for your T cells and B cells, which is going to act against self antigen. That's simple explanation of hygiene hypothesis. I'm not able to train the B and T lymphocytes properly because of less exposure when the kid was growing, so I'm going to have an autoimmune reaction, right? Smoking, again, smoking, the primary reason is smoking can definitely alter the gut flora. When the smoke particles goes and destroys epithelium, it may release few of the broken broken epithelial barriers, which might result in a new antigen formation, right? And an abnormal gut flora. Again, gut flora is very, very important for many functions. When I say abnormal gut flora, there are few increase in pathogenic microbe in the gut flora, which will result in production of antibodies, which indirectly will destroy the gut flora as well as the gut, right? Which primarily destroys the intestine or the intestinal epithelium, right? That's what an abnormal gut flora means. It's not like they're going to cause diarrhea or dysentery. It's simple thing like it's not normal. I'm having a little bit of movement here and there, so it's considered abnormal, destroying, and my gut also gets destroyed, right? Good evening, Christian, right? Those are the sporadic risk factors. Genetic risk factors, not to CARD50. These are actually not as not like receptor. They are NLRs, the receptor recognition receptors which can bind to multiple microbes. Not to is the one which says that okay, this is normal, this is abnormal, let's act, let's not act, right? And polymorphisms of not to, whenever you have genetic polymorphisms of not to, obviously it's going to mount an immune response against the gut normal commensal. Okay, normal bacteria which is there in the gut also will have an immune response, otherwise I won't have an immune response, right? Okay, when I say autophagy related thing, again these are just proposed genes, that's all, right? Good evening, Pramod. So autophagy normally is going to help to destroy the older cells and the older bacteria or the commensal bacteria which by mistake if it enters inside. So when I have a problem the autophagy related gene, that's going to take care of it as well, right? Obviously I will. Okay, so that's about your inflammatory bowel disease, sporadic and genetic risk factors, right? So once you come to the etiopathogenesis, can I say comfortably inflammatory bowel disease and T cell mediated problem? Kind of sitting on the wall of hypersensitivity autoimmune inflammatory condition, right? So whatever we read about the etiopathogenesis, it could be the sporadic or the genetic risk factor. The primary problem is it's going to make our immune system is going to act against the normal intestinal flora or your normal gut epithelium, right? So normal intestinal flora as well as the intestine, right? That's what it's going to do, right? So ultimately there are two things. So if the primarily is going to be mediated by T lymphocytes only. The primary mediation who is going to destroy them is the T cells are going to primarily fight against them. So if you know about T cells, I have Th1, I have Th2, I have Th17 response, right? Can anyone tell me what does Th1 does? Saccharomyces cerevisiae is one of the important organism which you have to know about abnormal gut flora. We have Th1, we have Th2, and we have Th17. Th1 primarily results in your granuloma formation, right? Th2 primarily is helpful in your asthma and allergic response. Th17 is acute on chronic inflammation, right? So whenever the T cell response is like Th1 more than Th17, it's going to result in a granuloma, which is going to primarily result in Crohn's disease, because Crohn's will have granuloma, right? Okay. So if at all in an exam, they're going to talk in detail about Crohn's disease. You already know how a granuloma is formed from chronic inflammation. You can write everything here. The only change is it's a gut organism, that's all, as opposed to a tuberculosis. Same mechanism, right? So if I have Th17 response, little bit more than Th1 response, that's going to cause acute on chronic inflammation. When it's going to cause an acute on chronic inflammation, it's going to result in ulcerative colitis. That's all. Okay. Same thing. The different outcome, different diseases, both are coming under inflammatory bowel disease. This is in short about the pathogenesis, right? We did read about the tables in our regular classes. Just to remember few things, both are chronic inflammation. Only thing I must have asked you to remember is Crohn's disease is what inflammation? Transmural or superficial mucosal? Crohn's is a transmural inflammation, right? It's a transmural inflammation, and ulcerative colitis is a superficial mucosal inflammation, right? I'm going to replicate what is there in the table of Robbins so that it will be much more clear. I do have macroscopic findings, we do have microscopic findings, and we do have few clinical presentations for ulcerative as well as Crohn's, right? This table will take care of almost everything required for ulcerative and Crohn's, but we just need to remember the transmural and the superficial mucosal inflammation alone, right? Yes, skip lesions also will be there in Crohn's, right? So when you look at Crohn's disease, the bowel being involved, right? It can be involved from the entire GIT. Here, it will predominantly be colon. It's colitis, right? Distribution, because of the entire GIT, I need to have skip lesions. If skip lesions is not there, the disease cannot survive, the patient cannot survive. This is diffuse or this is continuous involvement. It's completely involving, right? Since Crohn's has transmural inflammation, the stricture will be definitely more common here. Stricture will be common. Fistula, fissures will be common. If stricture is common, it's fibrosis, right? Stricture is nothing but fibrosis, entire thickness. So you'll have a thick bowel. The wall of the bowel will be very thick, but here rarely I'll have strictures. Instead of saying not will not happen, we use the term rare, and the bowel thickness will be normal because only superficial mucosal inflammation, right? Okay, so same thing, we are just extrapolating transmural and superficial, and we're going to repeat it. Fine. Predominantly Th17 response, Th2 will be allergic response. Allergic response will not happen here. Fine. Okay, got it. Let's go to the next one. So microscopic. So when you take about microscopic finding, again inflammation, that's what we primarily read about. We'll have a transmural inflammation. I'll have a superficial mucosal inflammation. Fine. Because of the superficial mucosal inflammation, the side projecting normal epithelium will look like a polyp. So it causes a pseudo polyp. Yes, here. Again, we don't write no, we use it of rare, right? It's a rare finding. That's all. Fine. Okay. Okay. Hi, Rishi. Fine. So when you come to ulcers, one is transmural throughout, right? So it is deep and knife-like, right? A deep and knife-like ulcers, and a superficial mucosal ulcerations are very superficial and broad-based ulcers. Since they are cutting deep and knife-like, that's when we have the cobblestone mucosa, right? Because of this, you have the cobblestone mucosa, which, if you remember, it looks like a pav bhaji, just cut deep through end to end, right? So you'll have cobblestone appearance on the mucosa, right? Lymphocytic inflammation, or lymphocyte, fibrosis, serositis, granuloma, all are intertwined. Whenever you have granuloma, You obviously will have lymphocytic infiltration, right? Yes, or marked infiltration. Whenever there's superficial mucosal granuloma, yes, you'll have fibrosis. It involves transmurally, so yes, you'll have serositis. Because of the serositis is where we can add one more thing. We have the creeping pad of fat also. The fat goes and tries to cover the serosal inflammation that results in creeping fat of fat. Again, because it's transmural, you'll have fissures and fistula. Here, mild, everything is mild, almost nil, all no, and no, right? Almost none, right? Okay. We'll read it after your exam, Rishang. There's lots more to read to inflammatory bowel disease than the 2 pages of Robbins. Fine. Okay. Rishi, maybe half an hour to 45 minutes later. Okay. So that's about the microscopy of your inflammatory bowel disease. Fine. Now let's come to clinical inflammation. Fine. Okay. So you go to clinical inflammation. So again, I'm just going to go with Robbins, but you can easily extrapolate it, right? Which of them will have perianal fistula? Throughout. Right? The entire GAT, oral cavity to anal canal, you'll have. Ultimately, fistula cannot happen in ulcerative because superficial, right? Fat vitamin malabsorption will be present because it's throughout. But here it's colonic, so I won't have it. Malignancy potential, both will increase the risk of intestinal colonic adenocarcinoma. Right, that's one of the complication. But I'm sure you know one more complication which is primarily seen only in case of an ulcerative colitis, which is the last one, toxic megacolon, because it destroys the Meyntrich and Meissner's plexus, so you can have a toxic megacolon, right? So here, very unlikely to have. Which of do you think will recur? Recurrence is obviously common here because complete GIT. I cannot strip off from mouth to the anal canal, right? So you cut a part of it, obviously will recur. But here, there'll be no recurrence after surgery because you do a colectomy. You remove the colon, obviously it will not happen, right? As simple as that, right? So all these we have read already in the form of a table. If you have your notes which you took in the class, just remember this. Rest everything we can extrapolate one by one, but you're divided in terms of macroscopic, microscopic, and your clinical presentation. So that will be taken care of, right? So if IBD is asked in an essay, what could be the probable clinical information, right? So we can divide them into intestinal and extraintestinal. IBD is generally seen in middle-aged adults or middle-aged young adults. So somewhere in the range of 20 to 40 is an age where IBD is predominantly common. Not exactly common in women, but because of the autoimmune inflammatory condition, slight predilection to the women, but that doesn't matter. But both the genders are more or less equally affected. Intestinal manifestation, you'll have pain, you'll have diarrhea with blood and mucus. That is very, very, very classical of inflammatory bowel disease. Intermittent diarrhea with blood and mucus is very, very classical of inflammatory bowel disease. Fine. Okay. And there'll be a feeling or urge to defecate. And you will not have exactly defecation. There'll be a feeling or urge to defecate. That's called as tenesmus, right? There'll be an urge to pass stools, but the patient will not be able to pass stools, right? Tenesmus, that's also a classical finding of inflammatory bowel disease, fine. Young person, male, female, doesn't matter, pain, intermittent diarrhea mixed with blood and mucus, that's a very classical finding. And urge to pass stools, think of an inflammatory bowel disease. Not just that, we also have extra intestinal manifestation, common in both ulcerative and any reason, Nishank? Hello, Divansh. It's seen in both ulcerative and Crohn's. Some of them are common in ulcerative, some of them are common in Crohn's, right? But don't forget, uveitis in joint and uvea will be more or less seen in both ulcerative colitis and Crohn's disease. Primary sclerosing cholangitis, it's predominantly common in ulcerative colitis patient, but not in Crohn's disease patient, right? So these are extra intestinal manifestation. So I can have a problem in the GIT and saying, okay, there is a problem in the eye as well, uveitis. Think of an IBD, right? So this is what will be then case of an IBD. We covered in short. Just will quickly recap IBD once again. Just for you guys, inflammatory bowel disease, risk factor, we have sporadic and genetic, whatever may be the risk factor, and my immune system is going to abnormally get activated against my self-antigen as well as my self-commensal. So T cell is going to be the primary player in the inflammation. Based on what is the predominant type of T cell, I have different type of diseases. Then we have your gross, we had your microscopy, and we have your clinical manifestation. Fine. Okay, that's fine. I'll sleep after that, Rishang. You guys still have to go and read after that, right? Okay, that's about your inflammatory bowel disease. You guys keep asking more questions and keep answering my questions. I will not feel tired. If you don't answer, it'll be very, very, very tough. Yes, Kashish, after peptic ulcer disease, I'll be covering about liver. Fine. Okay. So peptic ulcer disease, a very high possibility for you to get an exam, right? Be it a duodenal ulcer in the form of a question or a gastric ulcer, peptic ulcer disease might come. Please remember, this has to be very, very carefully answered in the Viva. We have discussed lots of, taken lots of time in the regular class and said that there's a difference between gastritis, gastric ulcer, and peptic ulcer. Peptic ulcer by definition means where the lining of the stomach or duodenum is broken due to pepsin and the gastric acid. If it's due to increased acidity and pepsin, I can use the term peptic ulcer. H. pylori gastritis is not peptic ulcer, but H. pylori gastritis can cause peptic ulcer. Both are very, very different. The problem here ultimately has to be due to increased acid production or reduced mucosal defense. When my mucosal defense is reduced, acid will automatically destroy me, right? So there are two things here. Few things can increase the acid production. Few things can reduce the protective response or your mucosal lining. So if that is reduced also, obviously there'll be more acid, and that will destroy my GI lining, right? So smoking, NSAIDs, you know how easily it can destroy. Alcohol, drugs, you know definitely more drugs than me which can increase the gastric acidity. Write them. H. pylori. This is something which is more important for me. Zollinger-Ellison syndrome, which is nothing but an gastrinoma. When it's a gastrinoma, obviously I'm going to have increased gastrin secretion. Increased gastrin secretion will increase HCl production. We look at H. pylori gastritis very soon. Fine. Rishank, it's like I said in the start, it's on the border of chronic inflammatory autoimmune disorder, but I can put it in the autoimmune category because self antigens or self GIT is getting destroyed. Fine. Okay. So when it comes to mucosal response, elderly by default, like every other organ, reduces to function. Mucin also reduces to function, right? Ischemia and shock by default is going to reduce blood supply. When the blood supply is reduced, obviously it can result in reduced mucosal production, right? So ultimately, when the balance between acid and the mucous layer in the stomach is altered in favor of acid, we are going to have peptic ulcer. That's it. Fine. So now let's have a quick look over the pathogenesis, because when you read the etiology itself, is very clear what is going to cause gastric ulcer, right? So when I talk about peptic ulcer disease, the predominant focus is going to be on H. pylori only. H. pylori is the predominant focus because that's one of the most common and the leading cause of peptic ulcer disease and chronic gastritis, right? Here, we'll write the drugs, the NSAIDs, we'll write shock, we'll write ischemia, and everything, right? Those are also is going to contribute, but predominant is going to be H. pylori only. In H. pylori, when you have a chronic H. pylori gastritis, it might not happen in acute H. pylori gastritis, only in chronic H. pylori gastritis. And it's chronic H. pylori. I want you guys to answer here, right? You don't want me to get bored. You guys are going to answer. H. pylori is an antral predominant gastritis or a body predominant gastritis? It obviously produces an antral predominant gastritis to start with. And then it can also become pan gastritis, right? Bale is good. Yeah. Fine. Perfect, right? So then when it becomes throughout the body, you also end up in having a patchy gastritis or patchy destruction of the gastric epithelium. This patchy destruction of the gastric mucosa is due to inflammation, because obviously H. pylori causes an inflammation which will patchily destroy the gastric mucosa, right? Patchy destruction of the gastric mucosa, that's why we also call H. pylori as an atrophic gastritis, not complete atrophy, patchy loss, right? Okay, fine. So then once we have the atrophic gastritis, this will reduce HCl secretion. Atrophy, right? Reduces HCl. When it reduces HCl, there will be a rebound increase in gastrin. So this becomes due to your G cell hyperplasia. Okay, so you have a G cell hyperplasia, increased gastrin will be there. So once gastrin is there, it will automatically increase the HCl production because it's only patchy destruction. I have rest of the gastric mucosa, the parietal chief cells are completely normal, right? Once it increases, obviously you're going to have peptic ulcers. Okay, you'll definitely end up having a peptic ulcer. That's the reason a H. pylori, primarily a chronic H. pylori, can result in a peptic ulcer, right? Because like we read in the start, Peptic ulcer is due to destruction of the gastric or the duodenal mucosa due to increased pepsin and gastric acid. And obviously, rest of them are easily explainable. Smoking or drugs or your ischemia or your pneumonic of Bale, everything, right? All those can be easily explained. Fine. Okay. So now, once we know the pathogenesis, clinical findings. It's a very simple thing. You guys answered yesterday itself. When something is aggravated by food, I think of a gastric ulcer. When something is relieved by food, I think of a duodenal ulcer, right? And late in the night pain, right? That also is going to be think of duodenal ulcer because in dinner you eat well, reduced, and later in the night, obviously the food reduces. There will be more effect of acid in the ulcerative area, which causes pain, right? And a late night pain is also suggests too often duodenal ulcer, and this undoubtedly is most common compared to gastric and duodenal ulcer, right? You might have melena. Melena is nothing but black and tarry stools, okay, which is due to upper GI bleeding. Okay, tiny upper GI bleeding can cause melena if there's a bleeding, right? Very, very rarely you might have hematemesis. If the ulcer erodes a major artery like a gastroepiploic artery, you might have hematemesis, but not very often in case of a gastric or a duodenal ulcer. But melena is something which is pretty common, fine? Okay, so we know the clinical findings and what are the lab investigation you might do. The first and the foremost thing, though they are talking about an peptic ulcer disease, I want you to do and I want you to write about H. pylori. You can do an urease breath test because predominant cause is this. There's no fun in just giving antacids. I have to identify what is the cause, then eliminate the cause, right? Urease breath test is mandatory if possible, and if the lab has the capability, I can do that, or I can do a stool antigen of H. pylori. That is an easy test, does not require radioactive carbon and everything, which can be easily do, right? See, it need not be due to an artery. If I'm going to see, if you're going to tear the skin, it will bleed, right? So the mucosal capillary, which is also ulcerated, will also bleed. Not in huge quantity, so it does not vomit or trigger the vomitus. It might slowly go along the intestine and come out in the stools. Fine. Okay. Yes, you're right, Yashashri. Endoscopy is required. Endoscopy is obviously the best one if and only if there is a doubt of malignancy. Or in a very long-standing case, I can do an endoscopy, take a biopsy to see if there's something going wrong, and also to do an GMSA test. GMSA test can easily pick up my H. pylori. Fine. Okay, that's what we'll do. Right. So now let's go to the gross. We did read about the malignant ulcer yesterday. You guys told about most of the features of malignant ulcer yesterday, right? Can you guys tell me what are the features of duodenal or a benign gastric ulcer? Benign as well as malignant gastric ulcer difference can definitely be asked in a viva. So the most common site is duodenum. Stomach, jejunum can also have. If you have ulcers in multiple sites or in unusual sites, when I say unusual, jejunum is also unusual. Ileum is definitely unusual. Always think of Zollinger-Ellison syndrome, right? You obviously think of Zollinger-Ellison syndrome if it's an unusual site and if it's multiple and if it's recurrent, we think of that, right? Okay, base is clear because of, why is the base clear? Because of the acid being destroying everything, right? Perfect. You will not have a heaped up margin. It will be flushed with the surface, right? You won't have a heaped up margin. You will have a exactly how to describe in grosses. You have mostly single, often 0.5 to 1 centimeter, very, very rarely beyond 2 to 4 centimeter. If it goes bigger, obviously I'm going to think of something else. It will be sharp. This word is what I want to look for in an exam or in a viva. Punched out. Heaped up margin is classical for a malignant ulcer. Punched out defect is classical for a benign peptic ulcer. Punched out. You drop an acid, obviously it will create a hole, right? No, Sheetal, it will not. Right? See, unless and until there is an coexisting GERD and Barrett's esophagus, esophageal adenocarcinoma is very, very not very common in our country. Fine. It's just for an MCQ they have designed like that. That's all. Fine. Okay. Perfect. And it should be exactly like this. And if you can draw, the mucosal folds, if you can draw a three-dimensional structure, right? The mucosal folds will reach till the margin. This is indirectly saying there is no heaped up margin, that's all. We just till the margin, that's very, very classical. And like you guys said in the start, the base will be clear. There'll be no necrosis. The reason for clear is peptic digestion. I have pepsin. So obviously anything is going to be there in the base is going to be digested by pepsin, because that's the reason for the ulcer as well. Fine. Hi, Praveen. Okay. Perfect, right? So all these are characteristic of a benign peptic ulcer. If you have a gross specimen, there's a very high possibility you might be asked to differentiate between benign and gastric. Two things which will attract the examiners, punched out here, heaped up margin there. Even if you forget anything, please at least don't forget these two. These two are mandatory, I expect, for a minimum 50% to give in the exam. Fine. Okay. Now let's go to microscopy. Microscopy primarily is not that important because no one does microscopy, to be honest, with respect to gastric ulcers, right? So, but if at all a microscopy comes, active ulcer and a healing ulcer, that's all. So when it's an active ulcer, you will have loss of lining epithelium. That's what ulcer primarily means. Along with that, you'll have necrotic areas plus or minus WBC infiltration. That's all. Okay. If a ulcer is healing slowly, below this, you'll have this will be the topmost layer. Below that, you will have area of healing tissue, that is area of granulation tissue. And if I go further below that, you will have the fibrotic lining as well. Obviously, any damage in my body will heal, and it will obviously will have healing, will always be with fibrosis. Fine. So try to do it, Kashish. Once you complete your theory exam, let's see if we can have a couple of things on your practicals. Fine. Okay. That's for your microscopy of an ulcer. Doesn't matter if I want to prove it's H. pylori, I can do a Giemsa stain. Giemsa stain will highlight H. pylori as tiny blue color curved rods in the attached to the epithelium. That's a classical description of a H. pylori. Fine. Okay. That will be respect to your microscopy of a benign gastric ulcer. Fine. What all do you think is a complication? Complication can be, one, easily it can bleed. It can go and breach an artery. It can bleed massively. One, long standing, it obviously has the capacity to become a malignant ulcer, right? Perforation is possible. Healing stricture is possible, right? Again, if it's a 5 mark for the entire peptic ulcer, naming it is more than enough, right? If it's a long answer, bleeding can be from damage to any underlying artery or a gastroepiploic artery, which might result in massive hematemesis. Fine. Perforation. Again, perforation is an emergency because the gastric contents will go into your peritoneal place, and the patient will present with guarding. Guarding is a phenomenon by which the entire abdomen will be very, very, very tight on palpation, right? That's protection, that's all. Guarding will be there and pain will be there, and you have to open up and close the area at the earliest. Stricture is seen in long-standing cases due to fibrosis. Okay. And malignancy by default is due to the H. pylori, not the benign peptic ulcer primarily. H. pylori can cause that. Fine. Okay. It's fine, Rishank. Okay. Peptic ulcer disease, I'll restrict myself to gastric adenocarcinoma. That should be enough. If you want to write Mal-Tumor issue, you can write, but I don't know how well your examiners will be welcoming for that. But at least don't forget gastric adenocarcinoma. But you're right. Whenever I have a H. pylori as the etiology, it will also end up in having a Mal-Tumor by default. Fine. So these are the different possibilities of complication which a peptic ulcer can have. Right. Perfect. Done. So that's all with respect to GIT. We read about stomach and colonic cancer, gastric and colonic cancer yesterday. Little bit about a peptic ulcer disease and inflammatory bowel disease, right? So with respect to liver, I obviously want to talk about your alcoholic liver disease, which we'll be doing second. But Trishang has been asking you lots of time to talk something about LFT, right? How many of you have seen reports of LFT of your friends, family members? At some point of time, some of your relatives, you might have, right? So LFT is something which is done almost on a regular basis in a lab. It's actually a biochemical test. Honestly speaking, it has nothing to do with pathology, except for few ifs and buts here, right? So if a question comes on liver function test, what do we do? Again, I need to start with a couple of lines, right? It's a panel of blood tests which assesses hepatocellular integrity. All are different tests. Biliary excretion. The bilirubin levels tells me whether it's proper or not. You must have heard about AST ALT levels, right? AST ALT level will tell me whether the hepatocellular integrity is normal or not, right? Okay, and synthetic capacity and the related metabolic functions, whether it's synthesizing properly, that will be help with the help of albumin, right? If the liver is functioning properly, albumin will definitely help in that, right? If the liver is functioning properly, my coagulation profile will be normal, PT will be normal, right? So I have multiple tests for every function of the liver. If my hepatocytes alone is damaged, some of them will be elevated. If the biliary excretion is damaged, some of them will be elevated, right? So it can help me in diagnosing, monitoring, and prognosticating liver disease. This is true for almost every test. I can diagnose liver failure, patient cirrhosis, or jaundice. And treating jaundice, I'll use bilirubin to follow up and prognosticate the liver disease, right? This is just a couple of words about liver function test, fine? So what all tests will come under liver function test? This is a basic panel, okay? So the terms SGOT, SGPT is long gone. Try not to use them. It's AST, ALT, that's all, fine? Alanine aminotransferase, aspartate aminotransferase, these both are hepatocellular injury marker. If my hepatocytes are damaged, maybe due to hepatitis or maybe due to alcohol, these are the two things which will be elevated, right? Whenever there's a cell, I'm going to destroy it, it comes outside. Simple necrosis, that's all. Hepatocyte damage, AST, ALT will be elevated. I'm not going to normal. I don't want you to remember normal as well. ALP. ALP is more like a whenever there's a cholestatic injury. We did read about cholestasis in multiple places, even when we read about jaundice, right? So wherever there's cholestasis, ALP, alkaline phosphatase, liver-specific alkaline phosphatase will be elevated. Alkaline phosphatase is multiple thing. Any cholestatic injury, it will be elevated, right? Or an obstructive, it will be elevated, right? Same here as well. Gamma GGT is again for obstruction or cholestasis. I'm writing it separately because GGT also will be a little bit elevated in alcohol-induced damage also, right? GGT is also very specific. When there's an obstruction, it goes and destroys the wall and it gets elevated, right? So that's for GGT, fine. Bilirubin, total, direct, indirect, is just to assess what is the problem here, right? If there is a direct bilirubin or a conjugated bilirubin elevated, right? If I say there's a conjugated hyperbilirubinemia, there's a problem in the excretion of bile, which might be intrahepatic, which might be extrahepatic. If there's an unconjugated hyperbilirubinemia, it could be an hemolysis, primarily hemolysis, or there's a possibility if both can be elevated, I can mark them as hepatocellular in nature, right? But this is, if one is elevated, other is elevated, I can have a clear-cut differential diagnosis, right? Albumin and prothrombin time. Albumin is due to it assesses my synthetic function of the liver, just function of the liver, but not in short term, long term. And PT, APTT, it assesses your coagulation factor synthesis. There's one important thing about PT, APTT, PT will see soon, fine? It's based on your coagulation factor synthesis, right? So there are multiple tests in the liver function profile and we will be able to differentiate everything here. No, if it's in the biliary tract, if it's inside the hepatocytes, it might not. GGT will be elevated if there's an obstruction, primarily in the obstructive jaundice. In the intrahepatic biliary radical or the extrahepatic, if there's a bile accumulation, it will increase it, fine. Cholestasis is anything when there's an obstruction, the the bile remains, we call it a cholestasis, right? Hepatocellular damage in sense, hepatitis will damage. Wilson's, hemochromatosis will damage the liver. trauma will damage the liver, right? That's a hepatocellular injury. Fine. Okay. Fine. So these are the different tests which can be done under the umbrella of liver function test, and we know what is the use case of each one of them. No, see, conjugated, unconjugated bilirubin, if bilirubin is not conjugated, no, it's very difficult for them to form a bile formation itself, right? Unconjugated bilirubin over the period of time will slowly get diffused into the blood circulation, and that's the reason it goes all over and it can cause pruritus as well, right? It's not that it cannot be excreted, but the excretion will definitely be affected. Fine. All or none never exists in medicine. Okay, perfect. So now we know what are the tests to be done, and there are actually patterns of injury. I can tell, okay, if this is elevated, I'll think of primarily this problem, a hepatocellular problem like Russian cast, or a cholestatic problem, or probably a mixed etiology as well, right? So whenever I have primary increase in AST and ALT, I think of an hepatocellular damage. The ratio also helps to some extent, not always, right, but it helps to some extent, right? If the ratio of AST to ALT, let's say AST is 100, okay, ALT is 40, the ratio is 2.5, right? So AST ALT ratio of more than or equal to 2 always suggests of an alcohol related liver problem. Again, not always, most of the time suggests like that, right? If it's less than 1, okay, it's less than 1, it suggests of an viral hepatic damage. Again, it just suggests. No one is going to diagnose viral hepatitis with this. We know we diagnose them with serology, that's all, right? So it's more than or equal to 2. I think of an alcohol-related damage, but again, I diagnose alcoholic liver disease with history, not with this, right? When it's cholestatic induced, I'll go for ALP predominant, fine? So when ALP as well as GGT is elevated, there's a definitely a probability of biliary obstruction or cholangitis. That's what we think of it, right? So when there is GGT as well as ALP elevated, there's a cholangitis or a biliary obstruction. Okay, GGT here is a little bit more specific than your ALT. GGT is generally the hepatic source of ALT. When GGT is elevated, see, there is biliary radical here, right? And I have hepatocytes close to it. When this gets damaged, the GGT and the ALP comes from the adjacent hepatocytes, right? That's what it means. I'm eroding the pipe. Slowly I'm eroding the pipe. So whatever is there very close to them is going to release the GGT and your ALP into the blood circulation, fine? Mixed pattern is like a mixture of both transaminase as well as ALP, right? So mixed pattern means I have increase in AST, ALT as well as I have increase in your GGT. That's both your cholestatic pattern and a hepatocellular pattern. Almost always think of primary sclerosing cholangitis. One of the differential diagnoses here is primary sclerosing cholangitis. There are lots of them, lots of differential diagnoses. You will read when you go to your medicine. This is just to at least write something for your 5-mark question, fine? Stool and this are different, right, Rishi? In a Rishank, for now we'll read this. Let your exam get over. You need to know a little bit of hepatology as well to answer. I'll definitely answer your questions, or when you go to medicine, Dr. Santosh will definitely answer those questions. Fine. Okay. See, obstructive jaundice as well, you'll have pale stools, right? See, stercobilin and urobilinogen, both are different. In an obstructive jaundice, the bilirubin is not entering into the ampulla of water. It's not going into the gut at all, right? So it becomes pale. In a prehepatic jaundice, that's different. Prehepatic jaundice is your hemolytic jaundice, where you have excess production. There's no obstruction there. So both are totally different things, right? Obstructive is different, prehepatic is different. Fine. Okay, Rishi? Okay. So these are patterns by which I can say, okay, this is probably related to hepatocellular, probably related to cholestatic. Fine. So synthetic functions and prognosis is based on albumin. Albumin always reflects a long-term problem. It's definitely not a short-term problem, right? Albumin is always a marker of chronic liver disease. Albumin also can be reduced in case of nephrotic syndrome, so don't get confused with that. If with respect to liver, it's always a problem of long-term capacity only, right? PTINR is always a marker of short-term failure, or in other words, a very early indicator. It's a very early indicator of liver failure, which means even before your AST ALT gets elevated, PTNR will be a problem, because one of the factor has a half-life in few hours. So today my liver stops functioning. Now within next 4-5 hours my PTNR might get deranged. So it's a very early indicator of your hepatocellular problem, right? That's with PTNR, and albumin is almost always for a long-term indication, right? So if at all an LFT comes in exam, write what's the definition, write the components of LFT, what all does it indicate, patterns of LFT, and a synthetic function, one for a long term and one for an early indicator. That should be more than enough. If you want to write more, give examples. Give examples of a Crigler-Najjar syndrome and say that, okay, there's going to be elevated, there's a conjugation defect, so unconjugated hyperbilirubinemia increases, right? That type of exams you can give a lot, but this should be more than enough for a 5-mark question, fine? Okay, now let's go to the big guy, alcoholic liver disease. So alcoholic liver disease, just a word, it's a spectrum of disorders directly related to excess alcohol intake. And there are 3 subgroups of this: alcoholic steatosis or fatty liver, alcoholic steatohepatitis, and the final terminal known as alcoholic cirrhosis. We'll definitely go to the pathogenesis. Before that, the risk factor, right? So we have the risk factor, gender, genetic polymorphism, and the most important thing is the amount of alcohol the person is going to take. This, though gender plays a role and genetic polymorphism plays a role, but it does not have a definitive role here, right? Which gender do you think is more prone for alcoholic liver disease? You guys know the answer, right? Females are more prone for alcoholic liver disease even when they consume the same amount of alcohol as men. One of the predominant reasons is the genetic polymorphism, right? Women are more prone compared to men for the same level of alcohol they ingest. The reason is, I do have pleomorphisms in aldehyde dehydrogenase. That's the enzyme which is going to convert your alcohol to acetaldehyde. When that is going to be problematic, that obviously will consume and alter the NADP ratio. That's one of the reasons why my liver is getting damaged with respect to alcoholic liver disease, right? Great. No, Rishi, any amount of alcohol is not good, right? This is just for exam purpose. 80 gram for a week is enough for us to cause hepatitis. More than 160 gram for 10 years is required to have cirrhosis. Fine. Yes, Rishi, females are more prone, but what matters is the volume. And here also they are indirectly indicating it's not the IQ which is important, it's the more number of hours you put in, you'll get more marks. See, if I can drink more for many years, still we can destroy the liver, and we will be always outlasting women in the category or the incidence of cirrhosis alone, right? So ultimately what matters is, these are just for namesake. Amount of alcohol you drink is directly proportional to the extent of damage. 80 gram for a week or 160 gram for more than 10 years will definitely result in cirrhosis, right? Let's compile the pathogenesis in a short, just in a type of flowchart, because we have read about pathogens of alcoholic hepatitis in 3 different categories of fatty liver, hepatitis, and cirrhosis. Let's kind of try to compare all of them together. A person consumes alcohol, right? So alcohol will be converted to aldehyde. Like I said before, aldehyde is always the toxin. Aldehyde for ethanol is acetaldehyde, for methanol is formaldehyde. Which year are you now in, Shreyansh? These are not for PG level, this is for undergraduate level only, right? Let's come back to this. So whenever aldehyde is there, whenever aldehyde is going to go into the mitochondria, in the mitochondria, aldehyde is going to get converted to acetic acid with the help of your aldehyde dehydrogenase. when it converts to acetic acid, this will reduce my NAD/NADPH ratio, okay, because it will be consumed. When NAD/NADPH ratio is consumed, I will not be able to recycle the free radicals, right? So this increases reactive oxygen species because of less recycling capacity of same glutathione peroxidase, what we read in your G6PD deficiency, same way, right? So when there's more amount of reactive oxygen species, same lipid peroxidation, DNA damage, and your protein denaturation, right? That will destroy liver or destroy hepatocytes. That's indirectly saying it's going to cause the second symptom, steatohepatitis, right? The same alteration of NADP, NADPH will do, Trishang. Just give me some time, we'll do it, fine? Okay. The same problem of consumption of or reduction of NADP, NADPH is other one which is going to increased fatty, your triglyceride production, and reduce the beta oxidation of fat, which is indirectly going to cause fatty liver. So if you are asked the question of fatty liver, redirect the pathogenesis. If you're asked the question of your steatohepatitis, redirect the pathogenesis here, right? The same aldehyde will cause, it's a direct toxin. So it's a direct toxin. There are two problems of anything being a direct toxin. It can directly damage hepatocytes, or they can produce intermediates, right? Or neoantigens. Or let's say this intermediates will stimulate immune cells, and that immune cells can directly destroy hepatocytes, right? Aldehyde can destroy hepatocytes in multiple problems, right? Protein attacks, right? So this is my this is my normal hepatocyte. Aldehyde comes, destroys it, breaks into half. Half broken hepatocyte cannot be left back, right? So my immune cells comes and removes that. That causes hepatocytic damage, right? It can cause protein attacks. It can directly destroy hepatocytes. It can alter the recycling capacity so that my hepatocytes will be more exposed to reactive oxygen species. That's one, right? In addition to that, when all these hepatocytes is causing injury, it's damage. It's indirectly inflammation, right? So when I have inflammation will always be followed by healing. And there's a chronic inflammation. Alcoholics are chronic by default. Whenever there's a chronic inflammation, that will activate your macrophages. Here macrophages are your Kupffer cells, right? So when it activates the Kupffer cells, and in addition to the activation of Kupffer cells, the same inflammatory cytokines will also activate one more cells in the space of disease called as Ito cells, right? Stellate cells. So when stellate cells and Kupffer cells are activated, that will increase your fibroblast or the myofibroblast in the instance, which increases collagen production, which causes the final guy cirrhosis. That will damage the entire liver. Fine. Okay. Okay. Perfect, right? So ultimately, this contains almost everything required for you. If you're talking about fatty liver as a short answer, stop with this. If the question is primarily on steatohepatitis as a short answer, stop with this. If it's cirrhosis, write everything. That's all, right? So in short, this is a pathogenic model of alcoholic liver disease, right? Okay. Ito cells, the stellate cells can definitely come in an exam. Please do remember that, or in a viva as well, or if it comes in a one-liner, remember. Stellate cells are the one which the final go to increase the fibroblast and produce collagen is based on stellate cells activation. Fine. Okay. Let's go to clinical features and lab. Clinical features for fatty liver primarily does not have a clinical feature. Most of them are incidentally diagnosed. Both alcoholic and non-alcoholic fatty liver does not have clinical features. Hepatitis may be very non-specific. Malaise, anorexia, weight loss. This might give a clue that something is problem in the liver and a tender hepatomegaly. But this will be the same feature for viral hepatitis also, or any hepatitis for the matter. This is not for alcoholic hepatitis, for hepatitis. Upper abdomen discomfort and your tender hepatomegaly suggests there's some problem or inflamed liver, right? Cirrhosis, there's a huge list of clinical symptoms. You guys tell me what all symptoms you already know. Damage is multifactorial. Yes, all of them can contribute to some extent to shrink. Okay, tell me what are the symptoms of cirrhosis, if you have gone to medicine postings, you must have definitely been to medicine postings. You have symptoms from head to foot, right? Right from loss of hair, the parotid gets enlarged, fetor hepaticus, spider nevi between the nipple, above the nipple and the upper chest, right? Wasting of the muscles and a very big pot belly. You have caput medusae. You might have variceal bleeding, portal hypertension, everything, right? You know everything about cirrhosis. Asterisk 6, I'll keep it for hepatic encephalopathy, right? That'll be a complication of cirrhosis, right? So you can have symptoms from head to foot. You should be able to write more than I know, right? Few things don't miss, which I'll be looking for in an exam. Fetor hepaticus, the foul smell, right? All the varices of portal hypertension. When I say all of them, which includes hemorrhoids, caput medusae, and your esophageal varices, because all of them are due to only one person, portal hypertension, right? All the portocaval anastomotic side. You can have in the esophageal varices, you can have in the rectum in the form of hemorrhoids, you can have in the abdomen in the form of caput medusae. Okay, and obviously the one thing which I cannot forget is ascites, right? Spider nevi is also very, very, very classical. Few, 3, 4, at least remember, that should be more than enough for you, right? But see, the problem of getting a question which you know is don't know when to stop. Please remember, in a long answer, there'll be sub-categorization. Okay, this is for 2 marks, this is for 3 marks. Write appropriately. Please don't keep on writing. At the end, you won't have enough time left for your one-liners, right? So please don't keep on writing for a question so that it'll engulf the time for the others as well, fine? Okay, now let's go to gross and microscopy. Gross microscopy for fatty liver, gross microscopy for hepatitis, and gross microscopy for cirrhosis as well. Just few words. You know how to write gross and microscopy, right? So gross of fatty liver will be enlarged. Okay, enlarged, yellowish. You can write any number. It can be like up to 3, 4 kgs, 4, 5 kgs also. Sometimes can be massive, sometimes may not be massive, right? If we can palpate, it'll be soft and greasy. Obviously, it's not something I can see and say it's greasy and soft. I have to palpate to say it's greasy and soft, right? Microscopy, I have two things. I have macrovascular steatosis and your microvesicular steatosis. If possible, draw diagrams. All of them will happen in which part of the liver? Will it be in the zone 3, zone 2 or zone 1? You have to try to stop it somehow, Rishan. Fine. Okay. So macro and microvesicular, put a central vein. Okay. Need not be extremely artistic. Just 2-3 lines, 2-3 rows, and straight everything is pink. Okay. Some areas where you want to show macrovesicular, put the nucleus alone in the corner. Rest everything is fat forming, right? In some places I have microvesicular. Okay, rest everything, put it pink, where still the nucleus is in the center, right? So you can say when the nucleus is in the center, that's an easy clue for me to say it's microvesicular steatosis, and the nucleus in the corner, it's easy for me to say the entire hepatocyte is filled with fat, which is macrovesicular steatosis. And you're right, all of the problems in alcoholic liver disease will start in the zone 3, including fibrosis, right? Everything will start from the zone 3. That's where all the enzymes are more active. That's where damage becomes more active, right? Okay. When it comes to hepatitis, grossly, I won't have much of a difference from a steatosis. It might not be soft and greasy. It might become a little bit firm. But here also, gross of hepatitis, the liver will be enlarged. But to feel, it will not be soft. It will be firm. Okay. Microscopy. 2-3 words I expect in case of hepatitis. What are they? Hepatitis can also have steatosis. It's not that it will be only hepatitis. It'll obviously steer to hepatitis, right? So fatty change will definitely be there. Fatty change will be there. You can write plus or minus, but most of the time it will be there. Few words which I want is one, ballooning degeneration of hepatocytes, which is nothing but saying that the entire hepatocyte is swollen. That's one. Perfect. And we cannot forget that guy, Mallory Denk or Mallory Highland body. Okay, Mallory Denk or Mallory Highland body. I want you to write. It's a non-specific finding. It's nothing but destroyed cytokeratin, CK8 and CK18, which gets accumulated inside. Fine. Okay. Mallory Denk is very, very important. If it's possible, put a cell, a nucleus, and a pink color. It's explained to be thick rope-like accumulation, which is nothing but destroyed protein, destroyed cytokeratin 8 and 18, right? It's thick rope-like accumulation of destroyed protein, right? Mallory body is required, right? Councilman, I would not write councilman here. You might see, but I will still reserve it to your hepatitis, your viral and bacterial hepatitis. Fine. Okay. Fine. Okay. You might see them. I'm not denying that. You might definitely see them. Fine. Last but not least, if required, right? Neutrophilic infiltration. Neutrophilic infiltration, especially surrounding the hepatocytes. That's very, very classical, because this helps me to differentiate non-alcoholic versus alcoholic. Around the damaged hepatocytes will tell, okay, this is probably an alcohol-induced liver damage. Fine. Okay, perfect. Next, last but not least, cirrhosis. Cirrhosis gross is simple. They are shrunken. This word is must. Shrunken liver with regenerative nodules. If it's not nodular, it is not cirrhosis. It has to have nodules. And based on the nodules, we divide them into less than 3 millimeter micronodular, more than 3 millimeter macronodular cirrhosis. Fine. Perfect. Okay, great. You will have bridging fibrosis, superb, regeneration is required, architecture is lost. If you have to go systematically, the earliest phase of cirrhosis, right? Where will you have the fibrosis? In the earliest phase of cirrhosis, especially somewhere near the zone 3, you will see them surrounding every hepatocyte, right? So in microscopy, predominantly findings are seen in zone 3. In the early stage of cirrhosis, you might see them pericellular fibrosis. This pericellular fibrosis is termed as chicken wire fibrosis, right? So later on, over the period of time, late stages, you will see fibrosis surrounding the regenerative nodules. Okay, this is what you'll be seeing in case of cirrhosis, but both of them are more or less required for me. Yes, you will have loss of architecture, you will have it. Shank, it didn't excrete fat. The cells got destroyed, right? Fibrosis is destruction. After that, tiny nodules is just coming up. When something is fibrotic, it will definitely become shrunken, right? Chicken wire pericellular in early stage, later stage you'll have fibrosis, and if you want, write a stain. The stain which can easily highlight fibrosis for me is Mason's trichrome. In the Mason's trichrome stain, the blue color fibrosis or collagen fibrosis will be highlighted. That's it, fine. Okay. That's with respect to your liver. Clean? Perfect. So we read about liver. Alcoholic liver disease is primarily fatty liver, steatohepatitis, and your cirrhosis. We read also about liver function test and your GIT. So that with respect to your GIT and liver, completed your essays portion, and let's today start with your FGT. Same routine. I want you guys to tell me not just the answer. I want you to tell me why did you come to the answer, and we'll see FGT and breast is not that important, but yes, we have to read them as well. Breast is definitely important. Sorry. Devyansh, I know you guys will tell the answer. I want to know why. See, know-how is the most important more than the diagnosis. Diagnosis, endometrial carcinoma. Carcinoma or cancer, both are fine. Obesity, diabetes mellitus, amazing. Still, see, there is a routine for me to choose or think about any question. Always it has to start with age, if it helps. Gender, if it helps. Here, gender doesn't matter. Here, obviously, I'm talking about endometrium. Age is important, right? The clinical data points is for me elderly age group. And then I do have a risk factor here. The patient is obese and diabetic, can probably have a metabolic syndrome. I'm assuming it could be a metabolic syndrome because that's one of the important etiological risk factor for your endometrial adenocarcinoma, right? And there's history of abdominal uterine bleeding. I'm sure by this time you must have gone to gynecology postings and gotten used to the term AUB, right? Worsening abdomen pain for the past 2 months. Ultrasound shows a thickened endometrium, right? So ultrasound, the thickened endometrium is not the problem here. This is the problem here. Is this normal? Because endometrial hyperplasia can also be thickened, right? Invasion is a problem, right? The most important thing in ultrasound is invasion into myometrium. Because otherwise, I can easily call it an endometrial hyperplasia also. I'm calling it, you called it endometrial adenocarcinoma, right? So obviously, I need to have the invasion is more characteristic for me here because endometrial hyperplasia will not go into the myometrium. Elderly, risk factors, abnormal uterine bleeding, invading into myometrium. So my most probable diagnosis, endometrial adenocarcinoma. Fine. That's why I'm taking the endometrial adenocarcinoma or endometrial carcinoma. If you say it cannot be adeno, fine. But theoretically, it most likely it's going to be endometrial adenocarcinoma only. Fine. Okay. Perfect. The next. What's the most probable diagnosis? Subhash, why did you say ILC? Again, my clinical clues start with age. Please don't forget the age. Elderly is almost always important for me. And also, on top of that, there is a family history of breast cancer. Okay, that's also important for us. And now the person is painless, not infectious. Firm lump. Okay, fibroadenoma can also be painless and firm, right? Gradually increasing size. Okay, fine. Nipple retraction and skin dimpling. Skin dimpling is your pure orange. That's more important for me, right? So there's a lump plus retracted nipple. You'll have a nipple retraction and there is dimpling in the skin. Plus ultrasound shows an irregular margins, right? A blood discharge. Okay, perfect. So most probably my diagnosis. Why, Rishank? I know why you're poking me on type 2 endometrial carcinoma. It's not type 2, it's type 1. I'll answer your question also why soon. Fine. Diagnosis here is most likely your breast cancer. Here, I don't want actually to write infiltrating ductal carcinoma or infiltrating lobular carcinoma. Anything is okay. Breast cancer is more than enough for me, right? Infiltrating lobular carcinoma, to tell it's an infiltrating lobular carcinoma, bilaterality, it should be a clue. And it should be a very vague lump, right? So I don't want you to jump into ILC unless and until you see bilateral mass and a very vague swelling. Okay, those two has to be there, or I need an Indian file pattern, then I can call it infiltrated lobular. More than enough breast cancer, and almost everything is infiltrating ductal only. Okay. Maybe you must have told infiltrated lobular because of family history. BRCA1, BRCA2 will still cause ductal carcinoma. That also will have a family history. Fine. Okay. Next. Diagnosis. Great, Devansh. You guys are still very happy just writing diagnosis, right? You're not wrong. I'm not saying you're not wrong. I always need this, right? Clinical history. Do you guys know what this is? Have you come across this term in your OBG posting? G0P0? You will come to know it when you go to OBG posting. G0P0 means gravida 0, para 0. In other words, I am telling she has not been pregnant before. Okay, that's what gravida 0, para 0 means, right? No pregnancy, no live birth. Okay, no pregnancy, no live birth. Indirectly saying infertility is a history here, nulliparity, right? Because endometriosis, one of the important presenting finding could be infertility. I have not told this person is having infertility problems, but still I put G0P0 here, fine? Okay, now a 2-year history of the most important thing which is important from here is this cyclical symptoms. I want you to highlight that. Okay, there's a problem cyclically. There's a pain during every cycle, dyspareunia, dysmenorrhea, and severe abdomen pain 1 to 2 days before menses and cyclically, right? That's very, very important. Retroverted antiverted is fine, and there's a palpable nodularity in the fornix that could be an endometrial deposit, right? And a tender, okay, nodularity could be an endometriotic deposit on palpation, right? So with the history and also maybe a subtle hint of your infertility, I'll think of endometriosis, but there's nothing concrete to call it endometriosis. If there's an ultrasonogram with a cyst, I can say it's a chocolate cyst, or you do a laparoscopy with the blackish spots on the ovary, that's diagnostic for endometriosis, fine. Ipsita, you can say in for any clinical history infiltrating ductal carcinoma because that's the most common. Lobular carcinoma of breast is unless and until I have bilaterality and vague nodular swelling. Or a breast cancer is more than enough. It's a clinical diagnosis, right? Explanation can be that of an IDC only. Okay, perfect. The same template what you've been going through with GIT, with liver and everything. Let's go to diseases. We'll be discussing about endometrial cancer, cervical cancer, endometrial cancer, endometriosis, and breast cancer, right? These are 4 things which you want to concentrate with respect to your female genital tract, and that should be more than enough. If it comes in an exam, it should help you, fine? Cervical cancer. Risk factors: multiple sexual partners, early sexual activity, and persistent infection with high oncogenic virus, which is 16, 18, 33, 37 as well. Good evening, Vinay. Low risk or low oncogenic viruses, your HPV 6 and 11 most likely causes genital warts. Since I'm talking about cervical cancer, we need not mention about that. Fine. Okay. And associated factors, smoking and immunodeficiency. The reason why this is important is these both will increase the chance of persistent infection. If the person is having a very amazing immunity, that can take care of the HPV virus, right? So when there's a persistent infection, the smoking and immunodeficiency can accentuate it. That can cause multiple changes in the entire genetics, fine? So when it comes to pathogenesis, we are talking about 2 common serotypes, HPV 16 and 18, and these 2 will integrate into human DNA. This word is very, very important. It's not in the episomal form. They'll integrate into the human DNA, and obviously we have 2 guys, E6 and we have E7. These are viral proteins of E6 and E7. Since they integrate with the human DNA, and these proteins will be produced with every cell division. Whenever my cell divides, these proteins are also produced. Fine, so I'll have an unlimited supply of E6 and E7, right? Great. E6 reduces or nullifies primarily my P53. E7 reduces or nullifies primarily my retinoblastoma. In addition to that, they have other functions also. but these are bare minimum, right? Because of these two damage or these two destruction or loss of function, I'm going to have an increased cell proliferation. And not just that, I'm losing p53. So there's a possibility I can have more and more and more mutations. And that primarily simply results in cervical cancer. Okay, it's a very simple pathogenesis. Okay, just listen, Rishan, that's all. You already know it. I'm just giving you a structure on what to write. That's it. Fine. Primarily squamous cell carcinoma. I don't want you to write adenocarcinoma because it's very, very minuscule. Predominantly cervical squamous cell carcinoma is more than enough for us, right? So we know the etiology, we know the pathogenesis, right? Then progression. Progression is an extra additional thing which we are adding in cervical carcinoma, which we didn't read in multiple other carcinomas, right? Because here you have a super progression from normal CAN 1, 2, 3, and then invasive cervical carcinoma, right? So from a normal cervical epithelium, we'll have L cell. That's the latest terminology. Okay. You write in bracket this equates to CAN 1 and 2. Then we have H cell, which is high-grade squamous intraepithelial lesion, which equates to CAN3 or carcinoma in situ. You can go with abbreviations at this point of time. Everyone in the who's correcting will know what is CAN1, 2, and 3, and also CAS, and also L cell and H cell, right? If required, write high-grade and low-grade squamous intraepithelial neoplasia, right? Finally, it goes to invasive squamous cell carcinoma. So what do I mean by L cell and H cell? Here, you'll have the dysplastic epithelium. Sorry, here only CN1, not 2. My mistake. Here will be CN2 as well as 3. Sorry for that. Okay. Dysplastic epithelium in the lower third. Okay. And obviously, you'll have coilocytes. Coilocytes will be there because those are nothing but the HPV related change which you can see in the microscope, right? Coilocytes nothing means you're going to have a clear intracytoplasmic inclusion with a shrunken raisin-like nucleus or a raisinoid nucleus. Okay, that's how a coilocyte looks like. Fine. Okay, it's fine, no issues. Then when it comes to 2 and 3, you'll have the dysplasia extending into the lower 2/3 for CAN2 and full thickness for CAN3. So full thickness dysplasia is also known as carcinoma in situ, right? So then invasion. So when the tumor cells are going to go into the cervical stroma, then I'm going to call them invasive squamous cell carcinoma of cervix, right? This is predominantly for squamous cell carcinoma. Adenocarcinoma also has a progression, but for an undergraduate, adenocarcinoma of cervix is not that much concentrated. This is more than enough. L cell, H cell, and invasive squamous cell carcinoma. Fine. Okay. That's for progression of cervical cancers. Okay. Clinical features. If it's a long answer, look for postcoital bleeding. Postcoital bleeding, elderly person, obviously it has to be a cervical carcinoma. That's something which I want you to remember always, right? Apart from that, we do have very non-specific findings which might not help us. Examination is important. If you've been to your OBG posting, you might have heard about these terms. If there is no visible mass, I do something called a visual inspection with acetic acid. You put acetic acid, there'll be very spotted areas, take a biopsy from that. If there's a visible mass, take a biopsy from the mass directly. That's important. That's how we investigate patients with cervical carcinoma. Screening. If there's a mass or a symptom, I don't screen. Screening is done for any person without a mass or a symptom, right? Screening is always done by pap smear. It has to be done as soon as or as early as whenever the person is sexually active. That's important. There's a guideline of how long to do pap smear. You will read them when you go to gynecology, right? Pap is a screening test. Pap is not a diagnostic test. They are viral proteins. Yes, Rishank. Rishi, let's not go into that. Fine. But yes, postcoital bleeding, 40-50 years is a very classical finding of cervical carcinoma. Fine. Okay. Let's go to gross and microscopic. The most common type of cervical carcinoma is squamous cell carcinoma. like more than 90 to 100%, close to 95 to 100% of them are squamous cell carcinomas as well. The other subtypes can be adenocarcinomas. You can have neuroendocrine tumors. You can have mesenchymal tumors as well. These are other rare things just to fill up the pages. Fine. By default, the most common squamous cell carcinoma, that's what you are expected to write in an exam as well. Fine. Okay. So gross of squamous cell carcinoma, like any squamous cell carcinoma in the body, it's going to be white in color, exophytic, cauliflower-like growth. Same here. If you can draw a diagram, great. Cervix, vaginal wall can have a ulceroproliferative lesion here, destroying the anterior or the posterior lip of cervix. Fine. Okay. Fine. So you have an ulceroproliferative mass. Okay. Which will be pearly white in color, cauliflower shaped. Okay. Sometimes it might have more superadded infection that might also emanate a very bad smell, right? Infections are common whenever there's lots of necrotic cells. Definitely infections are pretty common there. Fine. Okay. Okay. Then you come to microscopy. It's squamous cell carcinoma. I'll come to that. Give me a second. So squamous cell carcinoma, we have the same thing. We have keratin pearl. We have 4 feet of dysplasia. And obviously required for this is invasion. Okay, immunohistochemistry, same P63, P40, and add this addition is only for cervical cancer, P16. P16 is a marker of human papilloma virus activity. Whenever P16 is positive, I think that this patient has suffered from human papillomavirus. That can prove the etiology of squamous cell carcinoma of cervix. Fine. Okay. Okay. If I'll just ask you a simple question so that we can easily understand why do we use acetic acid, right? What is your nucleus made of? Deoxyribonucleic acid, right? So whenever there is nucleus, it attracts a specific part of the dye. Cytoplasm attracts a specific part of the dye. That's why we have the eosin hematoxylin, right? Like that, whenever the DNA content of a cell is more, which means cancer. When I use acetic acid or a toluidine blue, the color changes grossly. I don't need a microscope, right? Let's say it's a flushed skin. I'm putting a perspective examination, so not skin, cervix. I'm not seeing anything here. It's just a very smooth cervix. I'll just zoom this here. No tumor at all, but there's a history. Or pap smear showed an abnormal finding, but no tumor here. I don't know where to take biopsy from, right? So then I stain. So let's say, okay, this picks up the stain, this area. So I presume that this area, there is more nuclear content. So let's take a biopsy from here. Okay, that's the idea behind using all these cross stains, be it toluidine blue for oral cavity or an acetic acid for your cervical. Same idea. More nuclear content, it changes color from the rest of the normal. You take a biopsy, so there's more likely I will see abnormal cells in the microscope. Fine. That's the reason for using acetic acid. That's the reason for using toluidine blue as well. Okay. All right. Perfect. Treatment here, as usual, we know it is surgical removal. Here alone, I want to change the treatment a little bit, plus radiation. Not primarily chemo, it's radiation. Fine. Radiation after surgical removal. When you go to OBG, the points to give radiation, everything will be taught to you. Very, very important. Post cervical cancer radiation. That's something which is can come as a short note in your final years. Fine. Okay. Let's go to endometrial tumor. The same routine. Risk factor, etiopathogenesis, clinical, gross microscopy, gross and your IHC if required. Fine. And also a little bit about the treatment as well. Okay. Rishank, you must have asked the question that the history of that person was somewhere around 60, right? 60, obesity. So because you must have read that obesity and your diabetes, everything will predispose to type 1 endometrial adenocarcinoma, right? Which is generally seen in reproductive age group, right? Starts at reproductive age group. For every cancer, I have a 10 or 15 year of latency period. After that, it has to produce a mass. After that, the patient has to come to us, right? Though the type 1, the problem starts during your reproductive age group, they will present at 50, 60 only. But for type 2, the problem only starts at after postmenopausal. So they may present like 6th or 7th decade, a little bit later. Fine? Okay. I am not commenting on that, Rishi. Fine. After cervix, it can invade the vaginal wall. It can go into the uterine corpus. Those are the structures which it can go to. Fine. Okay. So we have risk factors: unopposed estrogen stimulation, obesity, hypertension, diabetes mellitus, or an metabolic syndrome X is a very, very important risk factor for type 1 endometrial adenocarcinoma. For type 2, it's primarily mutation related only. Infertility also might result in unopposed estrogen secretion. Associate factor is smoking. But if a question comes as a long answer with respect to endometrial cancer, don't restrict yourself to type 1, type 2 alone. I want you to write this as well. At least the name, not in detail, right? Because the recent one is your molecular classification. We don't classify endometrial tumors based on your type 1, type 2 anymore. It's always based on molecular classification from the past 2-3 years, fine? Ultra mutated or poly. Poly is your DNA polymerase epsilon. Mutated, hypermutated or microsatellite instability, microsatellite stable, and Cirrus like. Cirrus like is p53 mutated, right? These terms, if you can remember, great. Hyper, ultra, copy number high and copy number low. If you can't remember hyper, ultra, copy number low, pole E tumors, microsatellite unstable, that's your Lynch syndrome related. Lynch syndrome will have colonic cancers as well as endometrial cancer. Microsatellite stable, that your phosphoinositide triphosphate kinase AKT pathway, right? And your p53 mutated. These are 4 things. These are the new classification and a molecular classification of your endometrial carcinoma. Must to know and important to write, especially if it's a long answer. Short answer, ignore it. Fine. Okay. Pathogens and progression. From a pathogenic point of view, we always divide them into type 1 and type 2, right? So when you have type 1 endometrial adenocarcinoma, which is estrogen dependent. Okay. A type 2 endometrial adenocarcinoma is generally non-estrogen dependent. So that's why we say the type 1 starts during a reproductive age group. Type 2 starts post-menopausally. Fine. Okay. Great. Hello guys. Hope you're enjoying pathology and medicine. Fine. Type 1, because of estrogen, there is more cell division. More cell division by default can predispose to mutation. And the common mutation which is seen in type 1 endometrial adenocarcinoma, you have to write this. The most common mutation is PTEN. Most of them are related to PTEN mutations only. Arishank, it's obviously less work. I'm not denying that at all. It's more accurate. And the prognosis can be perfectly calibrated, right? Because of the accuracy is where I'm going there, right? Obviously, then MRI is definitely much easier than a clinical diagnosis. Why do I go for MRI? It's more accurate. That's our primary concern here, right? Okay. So here I have a precursor lesion called an endometrial hyperplasia. I can have an atypical endometrial hyperplasia that can cause more mutations and that can progress to endometrial adenocarcinoma. Type 1 causes few particular microscopic subtypes like an endometrioid variant, right? That is predominantly a type 1. The type 1 predominantly is in microscopy lab typical endometrial adenocarcinoma, the endometrioid type. Okay. Type 2, it's non-estrogen dependent, right? It's seen primarily in atrophic endometrium. In atrophic endometrium, what happens is it's going to primarily increase the risk of mutation, most likely TP53 loss. That's the starting point. In addition to TP53 loss, they also can harbor BRCA mutations. 1 and 2 loss can also be there. These are all acquired, not congenital, right? That results in a precursor lesion. We call it serous endometrial intraepithelial neoplasia. Fine. Here I'll have serous endometrial intraepithelial neoplasia like CAN. That results in endometrial adenocarcinoma. Microscopy of type 2, there are three types: serous, clear cell, and your mixed Mullerian, or ignore the term, carcinosarcoma. It's both carcinoma and a sarcoma. All these will come under type 2 endometrial adenocarcinomas. Fine. Perfect. Okay. Things not to miss. Estrogen, don't miss. P3, don't miss. P10, don't miss. And the microscopic subtype, if can remember that. Fine. That's what I specifically mentioned. These are acquired BRCA1, BRCA2, not congenital BRCA1, BRCA2. That's different. This is different. Fine. Okay. Perfect. So now we know the pathogens as well. Let's go to clinical features. Postmenopausal bleeding, right? Or postmenopausal spotting. Sometimes it might not be a complete through and through bleed, just spotting. Just tiny spots postmenopausal also should trigger an evaluation. I'm not saying it will be cancer, but there's a very high likely chance it can be cancer, right? Lab investigation, do a hysteroscopy. Hysteroscopy is like an endoscopy, but it's left into the cervical canal and to visualize the endometrium, right? And you take a biopsy. Can be a biopsy or can be a curettings. Can be any of them. If it's a thin endometrium, completely removed outside, little bit thicker, very big, take a biopsy alone to prove it's a problematic thing, fine? So when you take the biopsy, look at the gross as well as microscopy. Again, we'll divide them into type 1 and type 2. Though type 1 as well as type 2 might not predominantly differ in the gross, more or less same, both will, the tumor will grow and fills the endometrial cavity. It will entirely fill the endometrial cavity. Both of the places you will have hemorrhage and necrosis. The only slight difference grossly will be there might be papillary projections on the gross. May be there, not always, but that might not be there in case of a type 1 endometrial adenocarcinoma, and both will be highly necrotic mass, polypoidal mass, fleshy mass encroaching into the entire endometrial cavity, right? So when you go to microscopy, again we are going to look at the predominant type 1 and serous for type 2. I am not going to the clear cell and mixed Mullerian subtype, right? Type 1, like I said, it's endometrioid. So I'll have clear-cut glands, the 4 feet of dysplasia, but here the invasion is into the myometrium. I don't have anything below the endometrium, so I'll have myometrial invasion. Fine. Type 1 also has grading. Does anyone remember grading? Did you guys read about grading of type 1, what we discussed in the classes? We grade type 1 based on, yes, Ipsida, no family history. Based on the solid area present, right? That's how we divide type 1's grading. It's based on the solid area present. If it's more than 50%, we call it grade 3. It's a mixture of solid and the glandular elements. It's grade 1. Grade 2, it's predominantly well-formed glands. We call it grade 1, right? So grading is based on the solid areas under microscopy. Okay. More than 15, less than 15 is a very easy categorization. I hope it was much easier like that. If you feel that it's difficult to remember much of all the classification, that more than 15, less than 15 is also more than, it's okay, it's decent. But more than 50, it's type 3. Very well-formed glands is type 2, sorry, type 1, and well-formed glands and solid area is type 2. Fine. Okay. Sorry, grade 1. I mean, confusing grades and types. Sorry. Grade 1 is purely well-formed glands. Here you'll have glands plus solid areas, but it should be less than 50%. Whenever I have solid areas more than 50%, it's grade 3. And obviously grade 3 has the worst prognosis of all, right? Okay, let's go to type 2. Type 2, the predominant one for type 2 form here is serous. Whenever it's serous adenocarcinoma, what's a microscopy? You guys know, whatever is serous, you'll have papillae and you'll have psammoma bodies. Okay. And obviously, the 4 feet of dysplasia says without going, the invasion says without going. That's always a papillae psammoma bodies with a 4 feet of dysplasia and invasion, right? I don't have grading here, but by default, type 2 is high grade. Clear cell will have clear areas. Carcinosarcomas, that's also a type 2. Here you'll have both malignant epithelial and mesenchymal areas. It's carcinoma and a sarcoma, right? Both malignant epithelial and mesenchymal areas. Fine, great. Just last but not least, IHC and prognosis, which has worst prognosis. Type 2 definitely has a poor prognosis. Okay. IHC here, they are ER, PR positive tumors. This is ER, PR negative tumors, but P53 positive tumors. Whenever P53 is there, obviously they have a worse prognosis. Medicos channel, embryology question. Mesotome and mesenchyme, you should ask Pawar sir. I know something, but I don't want to give a wrong impression on the difference, embryological difference between mesotome and mesenchyme. Fine. Okay. I think mesotome is a broader category, mesenchyme is a subcategory for that. You guys should be better than me in embryology to explain that. Fine. It's not why papillary. See, it's a very simple thing, Rishank. Endometrium forms glands. So, less bad mutation causes glandular tumor. Very bad mutation causes sarcomatous, causes a papillary, causes a clear cell, which is not a normal endometrium's prototype, right? Glandular morphology, glandular tumor. Glandular morphology, non-glandular tumors. That means it's a bit aggressive mutation. That's it. Fine. Okay, that's with your endometrial adenocarcinomas, right? Let's go to quick look at endometriosis. Endometriosis, there is a possibility it can come in a short answer. If it comes in a short answer, mention these theories. One line about every theory, that should be more than enough. Because endometriosis is a pretty heavy theoretical subject. To write in a short answer, you should know how to stop it somewhere. Fine. Okay. Endometriosis by definition is endometrial glands. Please don't forget this. It's not only glands, it's glands and stroma outside endometrial cavity. Even in the tubes, it's endometriosis. Right? If it goes outside the endometrial cavity, we're going to call it an endometriosis. Simple regurgitation theory where the endometrial fluid can pass via the tubes into the peritoneum or into the ovary or into the uterine pouch, right? So it can go back. It's regurgitation. Benign metastatic theory where an endometrium, it's metastatic, right, can escape via spiral arteries. During menstruation, the spiral arteries undergoes thrombosis and breaks. Fine. Okay. I have a decent embryology then. Fine. Metaplastic theory. Metaplasia. It's change where there will be a coelomic metaplasia where my peritoneal lining can undergo metaplasia to give rise to endometrial lining. Right. Right. So there's an peritoneal lining can become metaplastic to endometrial lining. Okay. Stem cell progenitor theory. A stem cell can give rise to anything in the body. So this explains why I can have endometriosis in the lung, in the brain, in very distant organs. Fine. Come to Trishank. Fine. Okay. So here, stem cells, they differentiate to produce endometrial tissue. Fine. Okay, this explains all the distant sites where I can have endometriosis. Fine. Okay. Rishank, whatever you said is right. right? So when we look at the history of endometriosis, we believed a lot in this, but we couldn't explain how it can happen in liver or in the colon. Then we came up with multiple theories, right? So whatever you said is a very true fact. I have endometrium gland stroma, destroyed bleeding. It should die. It should not come back, right? That's when, if you remember us reading endometriosis, I also discussed that the endometrial tissue is not just a normal tissue. It has lots of mutations. It has lots of inflammatory cytokines going on, right? So it's a perpetual tissue, right? Initially, what we thought was different, but over the period of time, we understood that it's not just a normal tissue going and resting there and surviving forever. It cannot survive, right? So it has mutations. It has lots of pro-inflammatory cytokines. And if you remember, it has more increased estrogen and retinoic acid production. Retinoic acid production helps in differentiation and perpetual maintenance of the endometrial glands and stroma. Fine. Okay. Let's come back to this. Fine. So clinical features. Cyclicality is one of the most important clue, and the symptoms is based on the sites. Most common site is ovary, so you have dysmenorrhea, dyspareunia. If it's there in the colon, you'll have cyclical dysentery. It's bleeding, right? If it's there in the lungs, you might have cyclical hemoptysis. So the symptom is totally based on the organ where it is present. Fine, but everything has to be cyclical. Cyclicality is a very, very classical finding with respect to your endometriosis, right? Based on lung and colon, I'll have a different symptoms totally, right? Gross, most of the time, like the most common organ being ovary, it's dubbed as chocolate cyst. Be it a viva of endometriosis or a theory of endometriosis, don't stop it without writing chocolate cyst. Chocolate cyst, where you have a cystic ovary with collection of brownish fluid. The reason for brownish fluid is altered blood or hemosiderin. In addition to that, you'll also have, in long term, you'll have solid fibrotic areas as well, which ultimately will destroy the normal ovarian parenchyma. That's one reason why infertility is also pretty common in case patients with endometriosis. Fine. Okay, chocolates is very, very characteristic. Fine. Microscopy, what I'll see in microscopy is if it's ovary or any other organ, I'll see the normal organ parenchyma somewhere in the corner. But in microscopy, I'll see endometrial glands, not just the glands, plus the most important thing is you'll see endometrial stroma also. That's very, very important. I need to see the endometrial glands as well as the endometrial stroma. In addition to that, in long-standing cases, you'll always see hemosiderin laden macrophages. Sure, dears, after let's complete your theory, let's do the practicals as well. Spots of hemorrhage will be seen on the outer surface, right? It's on the outer surface. You see a spots of hemorrhage that's seen during laparoscopy, but the entire ovary, once you cut, it'll leak out brownish color fluid, which looks like a chocolate. Fine. Okay. IHC, just if I struggle with the diagnosis, CD10 will be positive in endometrial stroma. We're not going with markers for the glands because ERPR will be positive in normal ovary also, right? So CD10 will be positive in endometrial stroma. That's a very good marker which helps in the diagnosis, right? Long-term complication. The long-term complication is only one problem. Since endometriotic tissue is not just a normal tissue these days, there's lots of inflammation going on, lots of mutation going on, and self-sustenance going on. So long-term complication, at least in ovarian endometriosis, ovarian endometrioid adenocarcinoma. When we followed up people for a pretty long time, they ended up in having an ovarian endometrioid adenocarcinoma, right? Other places not that often, since like 60-70% of the endometriosis happens in the ovary. So obviously the incidence and prevalence of that will be more common compared to the rest of it, fine? If it's there in other parts of the body, resection is the treatment. We do have few drugs as well, but resection is ultimately treatment. Even for ovarian cyst, chocolate cyst, we remove the cyst. That should be the end of the story. Fine. Okay. That's with endometriosis. Rishi, you're just in second year, no? Come to surgery and OBG. They think very badly. Right? It's all human beings. What is there in your head comes out. Always you think of food, that's what is going to come out, right? Last but not least, let's have a quick look at breast cancer as well. Breast cancer, if I am an examiner, I'll definitely ask breast cancer in long answer because that's something I feel that every undergraduate should know in and out. Whether you are clearing your exam, you're not clearing your exam, breast cancer is something basic. It has to be known, right? So this is a table from Robbins. We divided them as relative risk of more than 4, 2 to 4, less than 2. Okay. We also read about what is relative risk means. If the relative risk of 4, the person is 4 times increased risk than a normal individual or a normal general population, right? This is a combined thing. Elderly women, that's enough to have more than 4 times relative risk of breast cancer compared to men. Very strong family history, more than one first degree relative involved, and a high breast density, which can be picked up by MRI. Okay, and these are all hereditary risk. Hereditary risk, we have genes with high penetrance. Okay, we have genes with moderate penetrance. Okay, high penetrance is relative risk of more than 4, moderate penetrance is relative risk of 2 to 4. That's all. Something not to miss: BRCA1, BRCA2, and CDH1. CDH1 is primarily for your lobular carcinoma. P10, STK11, TP53, if you can write, great, amazing. But please don't miss those two. That's important, right? ATM and check for moderate penetrance, fine. Related risk of 2, the sporadic risk, high dose radiation to the chest at a younger age, like Hodgkin's lymphoma, you give a radiation, that can cause a problem. Some of the vertebral disease also, you give a radiation, that also can cause a problem. And 1 first degree relative, this is more than 1. 1 first degree relative risk of 2 to 4. All these are risk due to hyperestrogenism. Okay. Whatever causes more estrogen levels, hyperestrogenism, all of them are relative risk of 2. They are the least important for me. Early menarche, late menopause, late first pregnancy, nulliparity, not breastfeeding, obesity, everything is relative risk 2, right? All these sporadic risk factors, fine. Okay. If it's a long answer, I think most likely it will come as a long answer question. I want you to write at least some details about inherited or hereditary or familial breast cancers. Okay. Don't use the term abbreviation BRCA for breast cancer. Please write breast cancer. I'm lazy, so I'm not using this. More fat. Okay, not more dense fat, right? Sponge is porous, right? Cloth is more dense. Both are made of fibers, right? More dense is extreme density of fat, which means more active estrogen production, more chance of growth and mutation. That's why. Fine. Okay. Familial breast cancer, close to 1/3 of breast cancers these days are familial. That too has come up. The incidence is increasing day by day because of more active testing going on. That's all. Fine. So BRCA1 and 2 is something, like I said, bare minimum. Know it, right? Because BRCA1 and BRCA2 alone accounts for close to 90% of inherited breast cancer. This accounts for 55% of breast cancers. This accounts for 35% of inherited breast cancers, right? Sporadic is different, inherited is different, okay? And if possible, remember the chromosome number. Chromosome 17 for BRCA1, 13 for BRCA2, right? It's in chromosome 17, it's in chromosome 13. Both BRCA1 and BRCA2, both normal function of both of them is they are both helped in chromosomal repair mechanisms. Then NHEJ, non-homologous homologous chromosome repair mechanism, that's a role of both of them. So they have problems in the repair mechanism. We know the pathogens easily. It's same like your Lynch syndrome, that's all. Fine. Yes, Rishi. Philostoma is different, right? Rishank, I cannot say that it's 27 times. It doesn't work like that, right? So, see, let's take if a person has BRCA1 mutation, they will have breast cancer even well before a normal population can have breast cancer, right? But they're at more risk, that's all. BRCA1 will increase the risk of breast cancer at 30, 40 years. This will increase the risk of breast cancer at 50, 60 years, right? So both are different here. Okay, I cannot add or multiply them at increased risk. They fall under this category: high risk, low risk, and moderate risk. Whatever one or both more of them if you have, right? Okay, come back to this. Okay, so the way by which it causes breast cancer is problems in chromosomal repair mechanism, more sustaining mutation, it causes breast cancer. That's all, right? But how do I know it's BRCA1 or BRCA2? Is the combination of cancers what we see in BRCA1 as well as BRCA2, fine? So BRCA1 as well as BRCA2, there are few common ones. You'll have breast cancer, you'll have ovarian cancer, fine. In BRCA1, there's also a possibility of fallopian tube cancer. Here, breast cancer, yes. Ovarian cancer, yes. But the most important clue is male breast cancer. Okay, there's an increased risk of male breast cancer with respect to BRCA2. BRCA1 cancers are most often triple negative cancers. BRCA2 cancers are most often ER positive cancers. Okay, these two at least I want you to write a bit in detail if it's a long answer. Other things I'm sure you'll write in detail. Pattern, endometrium, colon, breast. Right? Cowden syndrome, what you must have read. STK11, pure sugar, colon, stomach, pancreas, breast. We know the gene and we know the functionality. TB53, Leaf Romney. Sarcoma, leukemia, CNS, breast cancer. So those combinations helps me to think, okay, I'm talking about this particularly. Fine. Okay. Ataxia telangiectasia mutated, purely breast cancer, biallelic mutation, I have the problems in the immunity. Check is prostate, kidney, thyroid, and breast. Fine. Okay. So if you write these two and if you add a few more syndromes, that should be more than enough with respect to hereditary or a familial breast cancer. Fine. Okay. Now let's go to pathogenesis and progression. I'm going to concise the pathogenesis and progression, not going to go in detail much. Fine. Be it a sporadic cause of primarily documented by hyperestrogenism, which will by default increase the cell division. Okay. Or be it an inherited loss of BRCA1 or a BRCA2. Fine. Or a syndromic association of a BRCA1 or BRCA2. See, ultimately, both of them is going to cause multiple more mutations, right? More and more cell division, allow more mutation, right? So we have kind of three different pathways, be it a sporadic or a congenital for an ER positive, HER2 positive, and triple negative breast cancers, fine? So whatever may be it, the outcome, we're going to divide into three. Okay. Ultimately, sporadic and syndromic increase the risk of mutations. Fine. Okay. So when you have germline BRCA2, okay, this in addition gives rise to few more chromosomal abnormalities like 1q and 1q gain and 16q loss, right? All right, few more chromosomal errors, which results in a flat duct atypia, which increases phosphoinositol triphosphate kinase pathway, okay, which results in ER positive cancers. Okay, there is an flat epithelial atypia is a precursor here. Hello, epithelial atypia, then it will become DCIS. Once it becomes DCIS, it results in a cancer. Fine. Okay. When it's predominantly BRCA1 related, BRCA1 is your triple negative cancers, right? So BRCA1 will add on to more mutations, predominantly p53 mutation. Once p53 mutation happens in patients with BRCA1 loss, this causes again DCIS, that causes again triple negative cancers. Fine. If I don't have definitive BRCA1 or BRCA2 pathway, or if I have like Leaf Romney, germline problems, right? I might end up in having HER2 new amplification. Once there's an HER2 new amplification, it produces HER2 only cancer phenotypes. Fine. All these are for infiltrating ductal carcinoma. For a lobular carcinoma, it's different. Knudsen hypothesis will be present everywhere throughout the body for a tumor suppressor gene. Fine. So sporadic or syndromic, I have three pathways for ER positive, HER2 positive, and triple negative. If it's a ER positive, it's primarily dictated by BRCA2. In addition to a few more chromosomal errors, phosphoinositide triphosphate kinase pathway in the last, which results in cancer. Germline p53 loss, HER2 new amplification results in cancer. BRCA1 loss, I'll have a more again TP53 mutation, DCAs, and causes triple negative cancers, right? This is for ductal. Lobular, we know. Lobular, we read about same pathogens what we read in your diffuse gastric carcinoma. E-cadherin loss, loss of contact inhibition causes cancer. Great, Rishi. Okay, if it helps, you can use. Flat epithelial atypia means normal endometrial hyperplasia, atypical endometrial hyperplasia, cancer. Normal TDLU, flat TDLU with atypia, DCAS, cancer. Okay, that's just the microscopic terminology of the adenoma carcinoma sequence. Fine. Okay, let's go to your clinical features. By default, mass lesion plus or minus axillary lymph nodes. This lesion will be irregular, will be hard, right? Retraction of nipple, blood discharge, purely orange appearance, or skin dimpling are characteristic feature of breast cancer, right? Age should be there, elderly or a middle-aged patient if there's a family history. 30-40s can also have breast cancer if they are familial, right? Investigation, we go for mammogram if I don't have a palpable mass or if I suspect DCS. Biopsy, see if there's a patient with a clear-cut blood discharge and an axillary lymph node, don't go for this, just take a biopsy, that's all. Ideally same Rishank, but it depends on when it happens. See, it's going to follow the same ways. If BRCA1 is lost congenitally, it happens a little bit early. BRCA1 is got lost late, it'll happen a little bit late, that's all. Okay. Right? So once you take a biopsy or post-surgical, we can have gross and we can have microscopy as well. Gross IDC. What's the other name for infiltrating ductal carcinoma? A very classical name for infiltrating ductal carcinoma, we call it serous carcinoma of breast, right? So carcinomas of the breast are very, very, very firm, right? They are very firm. They are also called as serous carcinoma of breast. Okay. The size may be like 2 to 3 centimeter or 4-5 centimeters, but on cut surface, they are extremely whitish, infiltrative into the surrounding fat or the breast parenchyma, and they're extremely, extremely firm. Not even firm, they're extremely hard. Okay, and when you cut, you might have a different feel. That's why it's called serous carcinoma of breast, right? And yes, you might see areas of necrosis may or may not be present. This is primarily for IDC NOS, right? ILC, they'll have a very vague nodularity. They'll not be exactly defined, or you'll not be able to find exactly where the tumor starts and where the tumor ends, right? And bilaterality will be there, and there'll be a little bit of less desmoplasia. Not as serous, but yes, I'll see desmoplasia, but there'll be less desmoplasia for infiltrating lobular carcinomas. Fine. Microscopy. Everything here is about the microscopy, right? So in microscopy, if you remember, we saw multiple subtypes for IDC and also for ILC, right? So microscopy will divide like this. One word for everything. IDC NOS, you're going to have tubules with atypical cells, and you might have necrosis will be there. That's easy, very easy tubule formation. Mucinous, you'll have tumor cells floating in extracellular mucin. The mucin should be extracellular. I'll have predominantly mucin, tiny lakes, lands of tumor cells in between that. Tubular carcinoma, a very good prognosis. Very, very, very low grade tumor. You'll have more than 90% only well formed tubule. See, one of the important things I forgot for IDC analysis, there should be no myoepithelial lining. That is true for every IDC. DCS, I'll have myoepithelial lining. IDC, I won't have myoepithelial lining, right? Papillary, you know already. Papillary, I have again papillae plus samoma. And I have variant called as micropapillary. Micropapillary is again papillary projections without a papillae. It's just a projection like this, right? There'll be no central vessel. The only problem with micropapillary is they can break off and they have early metastatic potential. Okay. Medullary. Medullary means medulla is soft. Medullary tumors are softer, right? So medullary tumors, they are not infiltrative. They have pushing margins. Only when they are infiltrative, I'll have desmoplasia and becomes hard, right? Here there are pushing margins. You'll have lots and lots of lymphocytic infiltration. And you'll have sheets of tumor cells. You won't form tubules. Sheets of tumor cells, pushing margin and lymphocyte in the periphery, classical for medullary carcinoma of breast. Medullary carcinoma as well as the next one, metaplastic. Both are generally triple negative, which means they don't carry a good prognosis. Metaplastic carcinoma is in the name. So here IDC will be present, plus I might have squamous areas, or plus I might have sarcomatous areas. So it's metaplastic, fine. Pushing margins, you don't remember, Shan? Okay. Inflammatory carcinomas. Inflammatory carcinomas are more of clinical terminology, right? So here it's a high grade IDC only microscopically with excess of dermal infiltration. The dermal lymphatics infiltration will be, it's fine, Rishan. Because of the dermal lymphatic infiltration, there's a tiny bit of an edema and lots of puckering and the purely orange appearance happens. Clinically, it's a clinical finding. Microscopy, you won't have inflammation. It's a high-grade infiltrating rectal carcinoma only, right? Lobular carcinoma, you know the pattern. You have the classical Indian file appearance. Okay. Okay. Go back to your notes. I'll definitely have the pushing margin there. Fine. Okay, so these is a screenshot of what has to be written or what has to be revised in the last moment to know about different types of cancers microscopically. All these are special types. IDC and OSS, no special type or not otherwise specified. Fine. We have a grading system. This grading system is primarily done for IDC and OS based on the tubule formation, based on the nuclear features, based on the mitotic count. Modified Bloom-Richardson grading system is a grading system. Based on the grading system, we divide the IDC into 3 grades, 1, 2, and 3. Obviously, third being the higher grade. We need not remember how to score. Just remember this, how the scoring happens. Fine. Okay. The last but not the least, before treatment, we need a molecular classification. Lobular will not come under ICC. Lobular is a special type. That's all. Fine. So molecular classification, the best way to do a molecular classification is your gene expression profiling. Okay, that's the best way to do a molecular profile. But yes, but we do it based on immunohistochemistry, right? We do it based on immunohistochemistry, but the best way is to do gene expression profiling. Based on ERPR, HER2/neu, and Ki67. Luminal A is positive, negative, less than 14%. Okay. Luminal B, we have 2 subtypes in luminal B, positive, negative, more than or equal to 14%, which is highly proliferative. That's it, right? Here, triple positive, any amount of Ki. After this, any amount of Ki doesn't matter for me. I'll categorize them as different groups. Negative, positive, any Ki, negative, negative, any Ki. Okay, that's how we divide the molecular classification of breast. Which of these is more common? Which is the most common subtype? It is luminal A. Which has the best prognosis? Again, it is luminal A has the best prognosis, right? This is the most common subtype and this has the best prognosis. Okay. Luminal B is also, it's decent prognosis, not as best as luminal A. Fine. Your luminal B has also a good prognosis. HER2/neu will respond to your trastuzumab or antibodies to HER2/neu or your Herceptin. It responds to that. So if you can give Herceptin, it has a good decent prognosis, otherwise a poor prognosis. Triple negative, for these both, again I can give hormonal therapy. But for last one, there's only chemotherapy can be given. And they have the worst prognosis of all. Okay. I told this myself, Rishi, right? Genetics is easy. The only thing I have to do with genetics is make sure the machine is proper. If the machine is proper, the outcome is easier. Okay, that's with respect to your molecular classification, right? So if it's an essay pointer, obviously the risk factor carries 2-3 marks. Your familial BRCA, breast cancer, the genes can carry 2-3 marks. Pathogenesis is not much. Clinical features, couple of marks. Gross, microscopy, and the molecular classification will have the major chunk of marks. Fine. Okay, so that brings, I have to see under microscope also, because I have to know whether it's tumor or not, right? Someone reports not a tumor and I just look at genetics and report something else, I'll be in soup. Ipshita, it's called as pulseless disease because predominantly it involves the aorta, the branches of aorta, the subclavian. So the subclavian has a chronic inflammation, tissue destruction, healing by fibrosis. It'll get narrowed. So the volume of peripheral pulse, radial pulse becomes less. It's not absent pulse, low volume pulse. So we call it pulseless disease. Okay. Jen, what do you want in types of jaundice? We did discuss jaundice in the class, right? Jen, jaundice, you have a problem with hepatocellular jaundice because hepatocellular jaundice is a very vague classification, right? There are two extremities. One is prehepatic jaundice. The other is post-hepatic jaundice. These two are very well defined, right? Prehepatic is hemolytic anemia. Post-hepatic is obstruction, be it a gallstone, CBD stone, periampullary cancer. It's well defined, right? So when it comes to hepatocellular jaundice is not very well defined, which means there's a problem in the hepatocyte. This problem could be anything, could be a hepatitis. Hepatitis will have jaundice, but I will not diagnose hepatitis with jaundice. I'll confirm hepatitis with serology. Okay? Fine. So because hepatitis will have both conjugated and unconjugated bilirubin rise. If you ask me which will be more, I will not be able to say which will be more because it depends on the extent of damage, what is getting damaged, how much is getting blocked. Hepatitis will have both unconjugated bilirubin and conjugated bilirubin excess. But I will not diagnose or narrow it down as hepatitis based on jaundice or bilirubin levels. Here, my diagnosis is based on serology. Okay. Your hemochromatosis will also come under hepatocellular jaundice. Do you diagnose hemochromatosis based on bilirubin conjugated or unconjugated? No. Transference saturation. Wilson's will have more. Will I calculate Wilson's based on this? No. Based on copper urinary excretion. Prehepatic, I diagnose based on unconjugated bilirubinemia because it's very clear. Post-hepatic, I diagnose based on post-hepatic based on conjugated because again it's very clear with the help of pruritus and every other thing. Hepatocellular has a very vague category. This is acquired. This is acquired, right? Hepatocellular can also be congenital. So when I say congenital hepatocellular jaundice, it can be a problem in conjugation. It can be a problem in excretion. Right? Here I can have a clear distinction. Why not, Trishan? Tell me. Conjugated will have Crigler-Najjar syndrome and your Gilbert syndrome. Excretion will have your Dubin-Johnson syndrome and Rotar syndrome. See, Rishank, give me a question where you had a problem. We'll be able to solve the question. No one in the world can diagnose viral hepatitis without serology. It's not your problem, it's a question's problem. Okay? See, let's say I'm having hepatocytes here. Hepatocytes are in the form of a row, right? And in between the row, we have the sinusoids, and in between hepatocytes, we have the bile canaliculi, right? Let's assume all these are getting destroyed. Will I be able to properly conjugate bilirubin? No. Right? So unconjugated can be elevated? Yes. At the same time, these are destroyed cells. Can these destroyed cells, like in your acute kidney injury, can they block the biliary canaliculi? They can. So there's a combination of both will be elevated. Like I said, no one will be able to estimate what will be the quantity of increase in conjugated and what will be the quantity of increase in unconjugated, because I don't know what happens inside the body. It will be elevated, that's all. Fine. That's why you cannot, not just you, no one can diagnose its hepatocellular jaundice or what is the cause based on the jaundice level alone. Maybe this part I can to some extent, because conjugated problem will have unconjugated hyperbilirubinemia. This part no one can. Fine. If there's a, or you can use like this: purely conjugated, purely unconjugated, both increased, this could be the cause. That's maybe a very vague way to conclude that. Fine. Something would have been given in the question, Rishan. Without that, then the question is wrong. Don't worry about it. It's not your problem. Okay. Yeah, obviously nothing is, not everything will be affected, because everything affected will go to fulminant hepatic failure, right? Then I have bigger problems to assume than jaundice. Sure, once we'll do it. Enjoy your days for some time, because once you join MBBS, no, there's no relaxing back. Enjoy your time, join your college, let your counseling finish. We'll definitely start soon. Yes, Rishan. Clear? Don't have doubts. We'll do it. Why IDA in colon cancer? Because in colonic adenocarcinoma, there's a huge ulcerative lesion in colon. So slowly and steadily, like 0.1, 0.2 ml of blood leaks every single day. Like your Necator americanus, Ankylostoma duodenale. There the worm sucks, here it bleeds. Right? So that's why. Okay. Shoot, Rishank. What question you have in CVS? Yes, Rishank. You'll have atrial dilatation. See, that's what we read also, no? There'll be biatrial dilation. So ventricles have fibrosis, not able to expand. So this part of the heart will definitely be dilated, because that's what is pushing pressure. So there'll be biatrial dilatation in every case of restrictive cardiomyopathy. Yes, Rishi. Biatrial dilatation is classical for restrictive cardiomyopathy. Okay, Rishi, diacylglycerol, it's an I forgot the exact biochemical mechanism by which one of the toxic metabolites of diacylglycerol will be problematic for the receptor signaling. Because see, I'll give you a overall view. I don't know the exact chemical. I'll be very honest about that. If you read about glycogen storage disorders or mucopolysaccharidosis or phenylketonuria, you must have read that there's a problem in the phenylketonuria metabolism. So this enzyme is not working. So this component keeps accumulating. So this component will have multiple byproducts, right? So in phenylketonuria, the component's byproducts is what is going to affect learning, right? So that happens for every problem. So whenever a substrate increases, I'm not able to process in the normal direction, or when this increases, it will have multiple byproducts. One of the byproducts of mechanism will inhibit the receptors functioning. Okay, I forgot the exact chemical byproduct name, but that's what happens primarily in case of diacylglycerol in type 2 diabetes mellitus. Fine. Okay, see in HCM, hypertrophic obstructive cardiomyopathy, more than the atrial dilatation, the ventricles are so thick. That will be the predominant symptom, but yes, I will still have a left atrial dilatation there also. It will be bilateral hypertrophy, but left ventricle will be more than the right ventricle for the only reason that left ventricle pressure is more compared to the right ventricle pressure. Fine. It doesn't make any difference. It helps me to diagnose what is the problem based on the things. No, see, HOCM is a ventricular problem, right? Because atrium is, if you remember the anatomy of atria is not a very thick muscle. They are fragments of muscle. So hypertrophy generally does not happen in atrium. It's always dilatation and hypertrophy in atrium. Ventricles are proper muscle fibers. They'll become hypertrophic. Okay? Atrium is not involved. Atrium is a response. In RCM, ventricles are stuck. So atria response. That's all. Like toxic megacolon. This is the problem, but this gets dilated, right? But the problem is here. Same way, ventricle has a problem, there's a proximal dilatation. Fine? Okay? Okay, guys. So thank you for your time. See you, I think my next class on Saturday. See you by Saturday. My next class on Saturday, and I don't know what is my next class. You will get updated soon. I'll try to help you out. I think I'll be going with RBC disorders and coagulation, if I'm right. Just give a second. Yeah, my next class on Saturday, so Sunday, I'll be going with RBC disorders and coagulation. Fine. No. Rishank, first of all, in nutmeg liver, it's chronic venous congestion, right? It's not arterial, right? So chronic venous congestion happens from the central vein. So central vein drains to IVC. IVC drains to the heart. So whenever there's a right ventricular failure, the back pressure comes to the IVC, back pressure comes to the central vein, and it bleeds. So it has to be in the centrilobular. Okay. Okay, guys. See you on Sunday. Keep reading till then. Bye bye. Thank you.